Hello everybody, my name is Ken Henry. I'm the Associate Professor at Gallaudet University, and I'm also the Clinical Program Director at the clinic. I've been there for 6 months after doing adjunct work for 14, 15, possibly 16 years. What I'm going to talk to you about is patient referrals and the referral process, both to an outside referral or to a referral or recommendations for testing that you may do. Before I do that, I need to make a speaker disclosure, and that disclosure is that I have no financial information or interest in the presentation, and all of the monies that I receive from the presentation, such as honorarium, are all given back to the ASHA Foundation. So, again, we're going to talk about the referral process for further testing, or when the referral process is appropriate to refer outside, such as to an ENT. Now, we all know that vestibular assessment is within the scope of practice for audiologists, and that is well spelled out in ASHA best practice patterns, as well as the position statement by the Academy of Audiology. The thing about that particular scope of practice, however, there is a practicality issue that we need to address, and that is that many of the procedures that I may be talking about in the next half an hour are procedures that literally should be done by referral from a physician, just primarily because of insurance purposes. So some of these procedures can be recommended and performed by you, the audiologist, but many of them need to be performed under the recommendations, the direct recommendations of an ENT, a PCP, a neurologist, or a pediatrician. So again, it's within the scope of practice, but insurance is an issue that needs to be taken into consideration when doing these procedures, of course. In addition to it being within the scope of practice, there is a description of the referral process itself to an outside source, such as, again, as an ENT or a PCP or a neurologist. That is not well spelled out by either organization, other than saying that an appropriate referral should be made when it's warranted. Okay, so we're going to break this down into two parts. The first part is when the procedure should be performed based on what you find on your preliminary examination, and when it is appropriate to recommend an ENT referral prior to doing these procedures. So the decision for doing a vestibular workup on your part basically is very straightforward, much like any other presentation, any other diagnostic procedure that's done. And as you all well know, the very, very critical issue, the most important issue, is the case history, or the presenting complaints. And that's extremely important for audiology in terms of audiometry and in terms of vestibular assessment as well. The case report should be documented, should be well documented by way of course, the case history. And the case history is crucial in terms of justifying the additional procedures that you may consider, as well as justifying a referral, and also a very important part of the component for justifying the procedure itself to the insurance company. And finally, the third point here on the slide is based on clinical suspicion. What do you suspect based on the case report, based on the clinical presentation? And that, combined with testing that you've already done, such as an audiogram or a preliminary vestibular exam, that warrants further evaluation on your part. Now, unfortunately, there is no rubric, there is no flow chart that can tell us very straightforward if you find this, then do this. If you find this, then perform this procedure. There are some general guidelines, and I'll go over those general guidelines, as well as talk about some specific cases where particular procedures were recommended not by the otologist but by us, and those procedures themselves were very helpful to actually come up with a primary diagnosis. So we're going to use a template here to actually sort of discuss the options that you have before you. And the patient presents either with or without a referral to your office, and that patient may have auditory or vestibular or audiovestibular symptoms. And then the decision is to what to do about the vestibular symptoms themselves, okay? And what procedures you've already done with respect to those vestibular symptoms. And of course, the first and obvious objective is to provide a vestibular assessment. This is the key to the conversation for the next 20 minutes, and that is, what do you decide to do in terms of that vestibular assessment, or what recommendations that you may make in terms of that vestibular assessment that will help to make a diagnosis of the particular presenting complaints on the part of the patient. This particular bullet is an interesting one because it implies that, based on the case presentation, you may want to consider monitoring the systems, monitoring the actual clinical findings based on subjective report and so forth in the audiometric and vestibular findings, and may want to simply monitor the process. I'm going to get back into that a little bit later on, what the legal implications are for doing something like that. But again, that's also part and parcel of what we do in audiology, is what we do in vestibular assessment. And then finally, as I mentioned earlier, and that is that we're interested, and the focus of the presentation is deciding what we want to do about making further assessments in the realm of vestibular assessments, but when is it appropriate to make that referral to ENT prior to the vestibular testing being done? And again, at the expense of duplication, it's a very important concept here, and that is, unfortunately, many of the procedures that we would do need insurance authorization, which often means an insurance recommended referral by an ENT or other medical practitioner. A general template here, and we'll go into this in a little greater detail. Again, what I want to emphasize is that really what we're interested in here is, when you suspect a vestibular abnormality, what do you do next? And again, I can't provide a specific rubric or template by which we can say, if you find this, then this, because they're all very unique situations and very unique cases. At the end of the presentation, we'll go over a series of cases, again, that will reinforce that notion. So this is with respect to the need for referring to an outside source, such as, again, PCP, neurologist, ENT, or any other medical practitioner. And again, on the left-hand side of the screen, you can see that these are the classic Academy of Otolaryngology symptoms, signs, or findings for referring to an ENT. So those have been around for years and years, and as you can see, the third bullet, the fourth, fifth, and sixth bullets have to do with vestibular disturbances. So again, that would be incumbent on our part to refer to ENT when these particular findings are discovered. On the right-hand side, basically, is what we would consider referring based on the outcome of these particular procedures. In other words, these procedures, if there are a collection of abnormalities, it would be prudent for a referral to be made to an outside medical practitioner. So what I want to do next is again talk about a medical concept about vestibular evaluation, and that is the wait and see, watch and see, and recommend further testing. And if you remember from the flow chart, there is the section that I referred to as ambiguity. And ambiguity is the section whereby you have a collection of symptoms, and it is incumbent upon you to help to determine whether or not those findings are vestibular or non-vestibular findings. Okay? With respect to medical diagnosis, again, a wait and see process, which is to monitor the symptoms, is very often done with patients that present with non-specific complaints like simply dizziness. Watch and see would be to do serial studies, including serial audiometry, and look at changes over the course of time. And then finally, the third bullet here is to recommend further testing. Now, we aren't in a position per se to actually decide whether or not, based on what you're finding on a collection of symptoms or case presentation, whether we necessarily want to wait and see or watch and see. And in fact, if we suspect that there is a vestibular insult based on clinical suspicion and the findings of either testing or findings based on subjective report, then we really ought to use the watch and see or make a direct referral. And again, the watch and see would be to monitor the test results that have already been done, as well as performing any additional tests that you may want to do to come to a differential diagnosis. I mentioned that there is no rubric for actually coming up with a process of you found this or you suspect this, this is what your differential diagnosis is, and these are your clinical options and what tests that you can do. Again, this is an example of a rubric, but it's not inclusive, and that rubric itself would be impossible to do based on a collection of symptoms and signs themselves. Keep in mind, however, something like this can be used to develop a system that you can provide to your referring practitioners that in general you can say, if you suspect this, these are the collection of tests that we can perform to come up with a vestibular or non-vestibular diagnosis. So you can and should consider doing that kind of referral form whereby you actually set up a collection of abnormalities, a collection of symptoms, and the recommended tests that should be done. That form is something that certainly I can provide to you, the one that we have used in the past. What I want to do is I want to go over some case studies. The emphasis on the case studies are when the findings, the preliminary findings were conducted, and based on clinical suspicion, what did the audiologist decide to do in order to further the diagnostic process and come up with a diagnostic decision? Is it vestibular or non-vestibular? So the first case is Anna, and she's a 50-year-old female. She had a sudden onset left ear hearing loss, which she noticed, interestingly, on the phone. And she also had constant high-pitched tinnitus, and she noticed that after she attended a loud concert. She also has coexisting a history of episodic lightheadedness and imbalance. It started around the same time that the acoustic symptoms occurred, and she is reporting that the hearing loss and the symptoms are slowly getting more pronounced. Obviously, audiometry was performed, and these synopsize the findings of the audiogram itself, but the first case in point is that the audiometric findings were asymmetric. Okay, the left ear was significantly worse than the right ear. Who knows, maybe she might have had her left ear in the first row next to the woofer, but nonetheless, the hearing test showed that there's some asymmetry in the diagnostic procedure itself. The remainder of the examination, of course, is pretty straightforward. And of course, primary diagnosis would be in a case like this, hearing loss secondary to noise is acoustic trauma, obviously. And in findings with acoustic trauma, obviously, there's going to be a need and recommendation for serial studies to look and see whether or not there is recovery if the initial audiogram, of course, is done early enough post-insult. In this case, it was not, unfortunately. And it was also too late to actually make the recommendation to go to ENT to consider a possible course of medication such as steroids. In addition to the hearing test, obviously an ABR was recommended because of the asymmetric hearing loss. And the findings were rather equivocal because on the poor side, on the left side, wave 1 was not readily apparent. So we decided to do a VNG and a Vamp to evaluate labyrinthine involvement in this particular case. You'll see in the course of the next few evaluations that oftentimes we recommend a Vamp, and one of the primary reasons why we recommend the Vamp is it can easily be done in conjunction with an auditory brainstem response examination, number one. Number two, it is very fast and easy to do if the clinical protocol is set up appropriately. And number three, it is an extremely important procedure that corroborates the results of VNG testing. Okay, so again, that was recommended. And I would not find it surprising that an ENT would not make the recommendations to actually go further and evaluate the vestibular system. These again are the results of the vestibular examination. For the most part, they're unremarkable, with one exception, and that is that she was subjectively, not objectively, positive on Hall-Pike testing with the left ear down. So again, there was clinical suspicion that she may have had left BPV, which we could not document through the examination. Other than that, the examination was completely normal. Here is the results of the caloric testing, and again, very, very symmetric, no asymmetry on the caloric findings whatsoever. And here is the results of the Vamp examination. And in this particular case, a 500 hertz tone was used, and there was a significant amplitude asymmetry between the right and the left side, and that amplitude asymmetry is greater than 0.4, which is our upper limits of normal for Vamp testing for asymmetry. So that suggested the possibility of labyrinthine function on that side. What is interesting is that with follow-up testing, coming in for a conventional hearing examination, she reported that she was still dizzy, and that she reported that that dizziness was motion-provoked. A Hall-Pike examination was done, and the results of the Hall-Pike examination showed that it was indeed positive. These findings suggest the possibility of secondary BPV due to that initial trauma, not only to the cochlea, but to the vestibular system as well. What do you bring home with respect to this? And that is that serial follow-up with both audiometry and with vestibular assessment was helpful in this case. And when she came back for serial audiometry, or just a follow-up. That a Hallpike was done based on current symptomatology, and a diagnosis of secondary BPV was made. Next particular case is DP, and this gentleman had dizziness and loss of balance since 2010. He had an interesting antecedent history. His father was diagnosed with unilateral Meniere's disease, and some of his recent symptoms were dizziness, oscillopsia. Her symptoms are largely from the right ear. Pardon me, that's a she, not a he, and that she had pressure sensitivity from the right ear. Here is her audiogram, and again on the right side there is a low frequency hearing loss. In this case there is, however, an air bone gap at 500 Hertz. So again, the presence of that air bone gap is interesting, and acoustic reflexes were extremely important in this case. But the low tone audiometric finding is one that we would typically see with Meniere's disease. And other than the air bone gap at 500 Hertz, our first decision would be that this is likely Meniere's disease, and further recommendations should be made. Primary initial recommendation for something like that would be an electrocochleogram. Unfortunately, the contralateral cross acoustic stapedial reflexes were not done, but the ipsilateral reflexes were done, so that there is no evidence of any middle ear involvement. So there is the air bone gap that is still possibly clinically significant, but not for conventional conductive hearing loss. Here is the electrocochleogram that was done as part of the preliminary study. And the electrocochleogram is normal bilaterally, so that doesn't provide any different information to support the notion that he has Meniere's disease like his father did. Caloric testing was essentially symmetric. The caloric exam showed no evidence of any evidence of a permanent vestibulopathy. And then, interestingly enough, here is again a Vamp examination, and this Vamp is for the right ear. And at an extremely low level, we see the Vamp present. And 65 dB level is a level at which we would expect not to see the Vamp, because the Vamp basically is a pressure-mediated test, and at that low of a level, that amount of pressure in dB sensation level would not warrant seeing a response. So here's a case where the Vamp was extremely useful, and the recommendation for the Vamp is one that helps corroborate that there is a vestibular abnormality on the right side. Further testing was then again recommended. Platform posturography was done, and platform posturography showed a conventional 5-6 pattern suggesting vestibular abnormality. So now we have a differential diagnosis of superior canal dehiscence versus Meniere's disease. Additional testing was done doing platform posturography, as I mentioned, and a platform pressure test was performed. This was also positive. The notion is that the likelihood may be greater for superior canal dehiscence versus Meniere's disease, but a follow-up radiologic examination showed no evidence of canal dehiscence. So again, the differential diagnosis was based on a number of procedures, but that differential diagnosis was done primarily based on radiologic rather than audiologic or vestibular testing. Another case, this is CO, and he's a 57-year-old man with a history of traumatic brain injury. He fell down a flight of stairs, and he was in the Baltimore shock trauma unit for 3.5 weeks. Indeed, he was comatose. He had a right craniotomy and was transferred to a rehab facility. When we saw him, his hearing on the left side was completely gone. Interestingly enough, he did have some spontaneous nystagmus, significant spontaneous nystagmus, which was present 2 months after the initial insult. The caloric exam shows an obvious asymmetry, but in terms of the upper limits of normal, the caloric asymmetry or weakness was at 19%. So in this case, you say it's probably a vestibular as well as a cochleovestibular abnormality, but the clinical results don't support that completely. So a Vamp examination was done, and again, we don't know the presence of the possibility of any middle ear disease, which will ablate the Vamp response, but tympanometry was normal on this examination. And again, the right ear examination was actually present, but the latency between the left and the right side was very significant, on the order of 0.4 milliseconds longer on the right side. So that suggested an insult that is actually rostral to the vestibular system, the vestibular end organ. So this might imply an insult to the cochlear vestibular nerve as well. So Vamp was extremely important in this case. This is one that we recommended because many physicians don't understand that this procedure can be done in the presence of complete hearing loss. So again, the distinction is here. Even though the Vamp looks visually like it's present on both sides, which it is, there is a significant delay in the actual latency of the response itself, which again is abnormal and gives rise to support an abnormality on the right side, not just to the cochlea, but perhaps to the cochleovestibular nerve, the 8th nerve. A couple more case histories and then we'll be done. This is a 39-year-old man who has symptoms of brief positional vertigo, and that vertigo is worse when looking down. It is accompanied by nausea. The symptoms are very brief, lasting only 1 to 2 seconds. He has unilateral tinnitus, primarily in the right ear, so obviously we're suspicious of something like right BPV. Okay, he has a history of chronic headaches, and he gets, interestingly enough, symptomatology while chewing, and he feels as if his eyes move while chewing. So the differential diagnosis in this case is BPV. Could it be migraine-associated vertigo? Could it be oscillopsia, which would suggest a reduced vestibular response, otherwise not supported on the clinical presentation, or Tullio's phenomenon that he has the possibility of dehiscence syndrome. Most of the conventional testing that was done actually was normal. A dynamic visual acuity screening using a Snelling chart was normal. Unfortunately, at that time, we did not have a V-hit, which would have actually been a way of objectively verifying the possibility, the clinical possibility of oscillopsia. But this was done only based on a subjective procedure, not an objective procedure. The VNG was normal, the audiogram was normal, the ABR was abnormal, and again, those were all recommended, but the Vamp was recommended on the part of the audiologist. And as you can see, there is a significant asymmetry between the right ear and the left ear. The amplitude on the left side is on the order of magnitude of over 3 times the size of the response than on the right side. And again, the response is absent at the lower level, so there is no evidence of canal dehiscence based on the examination, but the Vamp itself, the amplitude asymmetry at 95 dB was significant. So in that particular case, again, the only clinical finding that could corroborate his clinical presentation was the Vamp. Another case is Kathy. She's a 57-year-old female with dizziness that comes and goes. It's been intermittent since 2012. She has motion-provoked dizziness with sudden movement, and also with movement of the visual surroundings. She has oral pressure, fullness, and tinnitus in the right ear. A prior series of studies in 2010, she had a normal examination for the most part. She refused the VNG examination. So here's a case where clinically not much could be done simply because the ENG was deferred by the patient. Here's an example, another example of where the Vamp is beneficial. And again, the Vamp on the right side is much more robust than on the left side. And interestingly enough, this is the contralateral side to the subjective report of the symptomatology being on the right side. With that said, this is a conventional or an atypical case, but the Vamp was one of the primary tools that allowed us to actually document findings of an abnormal vestibular insult. Because there are no other findings other than this particular test, however, it's important to consider that this is not a concrete diagnosis of a vestibular insult on the left side. And serial studies were recommended as a result of the findings being soft, so to speak. So serial audiometry and serial Vamp examinations were recommended. She also had, I forgot to mention, a cochlear hydrops masking technique, which is also a test that is used for assessing Meniere's disease, and the findings on that particular procedure were also normal. What are our recommendations? How do we know what to do next? How do we know when to refer to a primary care physician? How do we quantify or objectify what we do? And as I mentioned in the earlier part of the presentation, that there is no tried and true process or flow chart or rubric that can tell us if you find these symptoms, then you want to do these procedures. Again, the serial test battery, the full test battery, is always helpful, as we already know, but these are the recommendations, the tests that are extremely helpful and can give you a pretty good idea, pretty good assessment of vestibular versus non-vestibular. But the bottom line again is that there is no one process that you can adhere to decide what the next test will be that you will utilize. It's all based on clinical presentation, symptomatology, and it's based on the initial presentation of the diagnostic procedures that were done. Thank you very much. Thank you for allowing me the opportunity to talk to you. I know it sounded like a lecture on Vamp testing, but again, these are procedures that are very easy to do and very fast and efficient. Thank you.